good afternoon again, and welcome to today's Ask the Expert webinar series on emerging issues in practice management in Victoria. Thanks for joining us. In the spirit of reconciliation, Avant acknowledges the traditional custodians of country throughout Australia and their connections to land, sea and community. We pay our respect to their elders past and present and extend that respect to all Aboriginal and Torres Strait Islander peoples today. So we do have a lot of people online, which is absolutely fantastic. We also do encourage you to visit our recently updated Avant website, where you can find the latest news and resources, including our up-to-date COVID-19 FAQs. So again, all our attendees are on mute. Please do send any comments through to our panelists via the chat function. Lastly, a reminder that all our advice here today is general in nature. We do invite you to contact Avant's Medico-Legal Advisory Service for any specific questions you may have. And at the end of the webinar, you will also see, we ask you to take a moment to fill out a short survey. Well, we do have a full panel of experts for you today. And before we kick off, I'd like to introduce our facilitator, Cheryl Wood, an Avant risk advisor based right here in Victoria. Cheryl is a certified practice manager with extensive experience in managing specialist medical practices across regional and metro areas of Victoria, as well as New York City. She's a past state AAPM committee member and was previously the executive officer of the Inner East Primary Care Partnership. Cheryl's passion is lifelong learning with a specific focus on the value of mutually beneficial partnerships. Thank you, and over to you, Cheryl.
Thank you, Peter. I appreciate it. Welcome. I hope you're all sitting back and looking forward to an interesting and informative chat. I'm joined here today with Mariana Kelly, who many of you may know as a risk advisor with Avant, as well as Sonia Black, who is a workplace law team for Avant. Today we'll be discussing managing staff in the current environment, supporting patients to return to face-to-face appointments, as well as recent developments in employment law that will impact the medical practices. We do invite you to put any questions that you might have into the chat function, and we will try and address any of those questions. If you do have a burning question that we don't have time to answer, we do invite you to contact the MLAS team, and the number is on the website. So we'll begin. So it has been a tough time over the past few years, and the recent floods have not helped. As we hope to get back to normal, you're now faced with other issues. We are aware lots of staff are absent from the practice. This includes support staff and medical practitioners. When we refer to staff today, we are referring to both support staff and medical practitioners. And I do acknowledge that we've been isolated a little in Victoria, thankfully, from the flood conditions that other states in the north have been experiencing, but we've certainly been impacted by COVID, and that's similar issues for us. So to Sonia, from an Avant employment lawyer perspective, how do you manage staff who don't want to return to the practice? Can you terminate their employment if they do not wish to return, but keep delaying with excuses relating to COVID? Are there any other thoughts?
Great, thanks Cheryl, and good afternoon everyone. Welcome to our webinar. So this is an issue we're now seeing as things return to normal, in inverted commas. A lot of staff who haven't been at work physically in the practice or going to work for a period are still wanting to work from home. And I know with a number of the doctors who've been doing telehealth from home, that creates a burden on other doctors who are doing more of the face-to-face work, and similarly for administrative staff. So you can require staff to return to the physical practice if it is a reasonable and lawful requirement to do so. So what you really need to do is to conduct an assessment of your business needs. And if you can demonstrate that you actually do need people to physically be at your practice to do their job, that becomes an inherent requirement of their job, and we can assist you with a process to get them back into work.
Thank you, Sonia. And from another perspective, how does the practice owner and the practice manager manage a staff member who refuses to be vaccinated, particularly when we've got the requirement for healthcare workers to be vaccinated?
So we're still seeing this. We've had a lot of practices who allowed staff to either work from home or to take leave for the initial few months of the vaccine mandates. But now they've reached a point where practices are getting very, very busy with patients coming back in, flu vax, COVID vax, face-to-face appointments returning, and they need staff in the practice. So what we're recommending is, firstly, there have been a number of Fair Work Commission decisions where the Fair Work Commission has supported an employer's dismissal of an employee who refuses to be vaccinated, both where there's a public health direction and where there's not. The two most important things for practices to consider are, firstly, whether the employee can do their job from home, and secondly, whether the practice can continue to accommodate unpaid leave for the employee. So if the employee can't do their job from home and the practice can't accommodate unpaid leave, you can take steps to bring that the unvaccinated employee's employment to an end.
Thank you. Mariana, what are some of the risk strategies that practices can put in place to reassure staff it is a safe workplace to return to? You're on mute, Mariana.
Sorry, welcome everybody. It's great to sort of be part of this sort of session again. It seems like ages since we've all got together. Hopefully we can face-to-face soon. Some of the risk management strategies that we recommend is to make sure that there are risk assessments conducted in the practice to do with managing COVID, really to do with managing infection control generally, which we'll talk a bit about a bit later as far as other issues that you could be presented with. But remembering that once you've done the risk assessment, that it's not a static process, it has to be an ongoing review, engage the staff as part of that brainstorming, discuss concerns, have an opportunity that is ongoing, check in where there are any problems to do with what the risk assessment may have been even 2 weeks ago as compared to now. And when the staff see that that is an ongoing process and they are engaged in that and their opinion is valued, I think that will help to reassure them that they are actually being looked after, that the employer and the practice manager does care about them, and that they don't have any more concerns any more than the average person, I guess, or any more than if you're at some function. There's the usual appropriate controls that they have to do individually, but that will be through education from the practice as well. And as I said, I think the most important thing, of course, document the risk assessment, but to make sure that you do not see it as a static process, because as you know, it's been forever changing. The rules change, the mandates change, so you've got to keep up with it and reassure the staff along the way.
Thanks, Mariana. To that end, though, how does the practice manager manage staff and that risk with face mask mandates being lifted? Have you got any thoughts on that?
Yeah, I will give one comment about that, and I'd like to pull Sonia in. Sonia has been our absolute leader in a lot of this with them. She's got some great ideas, particularly from an employment perspective. But again, I think pretty much the way I see it from a risk advisory viewpoint is that the healthcare workers are vulnerable, and whatever the practice decides needs to be in place to reassure the practice staff that it's there for their sake, that they want to be making sure that they're looking after them, and that they will keep up to date with the current guidelines and do everything possible to reassure them. And if that means that the practice has decided that face masks are still going to be expected to be worn, then that is absolutely what should occur. And Sonia, I'd like to ask you at this point, as we know, the guidelines and TAGI, often changes, but, healthcare workers is also, because it's mandated about masks still being worn for healthcare workers, and that still applies to private medical practice. Is that the case?
So throughout this, Mariana, there's been two pillars really around face masks. The first pillar has been the public health directions and what the public health directions say about face masks. The second pillar is the medical practice's own risk assessment and its own obligation to ensure health and safety at work. So even if there isn't a public health direction mandating face masks in the practice itself can determine that face masks are a necessary control measure in order to keep patients, staff and others safe in the practice.
Mm-hmm.
And that's certainly the advice, the current advice from ATAGI and others is that PPE is one of the frontline avenues to keep people, doctors, nurses, reception staff safe.
When you talk about PPE though, can you clarify that a little bit more? Because in the private medical practice setting, of course, it's very different to the COVID ward or to the ICU. So when we're talking about masks and protection in the private medical setting, what would you be suggesting that the guidelines particularly applicable to private medical practice is at the moment?
So each state and territory, of course, has its own guidelines. So the first thing I'd suggest you do is to have a look at the current Victorian Department of Health guidelines. They have specific guidelines about private medical practice and what PPE is required. The other thing that the Victorian Department of Health has issued is guidance for what happens when there has been a COVID exposure in your practice. And that guidance says, if you had this PPE and you had this in place, then you don't have to close your practice. If you had this PPE and this in place, you have to close your practice. So I suggest review a combination of those two documents, and then you can determine your PPE requirements, which include, do you need face masks, cloth face masks, N95s, whatever.
Yeah. And I mean, of course, as we've said, this is forever changing, isn't it? And I think it's good to remind people that the FAQs on the event website are really a great resource. And Sonia has certainly been very instrumental in putting them in place. And I personally, even as an event employee and a risk advisor at the event, has found them invaluable. So I think just keep looking at that as well, because there's some really practical advice on those FAQs.
Yeah, and we're trying to get stuff up there as it becomes relevant. When we're getting calls to our MMIS line, we try and develop an FAQ quickly and get the information out there.
Mm.
And I have to admit, having just recently started with Avant, having come from a practice, I was surprised at the number of resources that are available to practice managers. So certainly if you haven't looked at the resources that are available, there is a lot for both your doctors and for the practice managers. So Sonia, getting back to the PPE and COVID, and we want to move on, and unfortunately it seems to be the gift that keeps on giving. What do you see could be the extra problems which could present with the flu season coming, relating to flu and COVID and other respiratory illnesses that we've largely not had to deal with the last couple of years?
So from what the medical advice is, we're in for a cracker flu season, and we're going to be getting a lot of respiratory illnesses that we haven't had in recent years. From the practice's perspective, there's a couple of issues. First of all, the flu clinics are starting. So it's managing flu clinics, COVID clinics with staff in isolation, reduced staff numbers, and trying to keep everyone safe in those clinics. Whether you run clinics at the same time, different times, whether people have their COVID booster and their flu shot at the same time, those sort of things create administrative difficulties. And I think you need to do a lot of planning and prep to ensure that all your paperwork and consents and everything are good for those. The other issue, of course, is that we have started to see, doctors are telling us they've had their first influenza A patients through the practices, and it's impossible to tell when a patient presents whether it's COVID, influenza, or some other respiratory illness. So I think we have to, throughout this flu season, until sort of August, September, we need to just stay very alert. We need to stay on top of infection control and on top of PPE requirements, because it is going to be a difficult 6 months.
And I couldn't agree with Sonia more from a risk management perspective. And I think be prepared, because if COVID has taught us anything, it is the importance of planning. Having the strategies and monitoring in place in an ongoing manner, as we said before. In the past, RACGP, for example, worked on disaster planning, if you remember SARS, and there was all this planning that was in place. And then when COVID happened, it was like, where was that ever put into place? It was there, but it was never really put into place for a lot of the practices. So I think, what you've learned through the pandemic, what you've put into place, keep reviewing, is it working? What other strategies need to be put in place, and use the whole team to develop those strategies, because sometimes I think we really undervalue what even some of our support staff can contribute to these conversations, because somebody might have a light bulb moment which has a domino effect, which can assist practices greatly. And I appreciate it's really difficult at the moment. Some of the doctors have reduced their workload, and the biggest question for some of you, I guess, is through the flu season and including the flu vaccination clinics, do we have enough doctors scheduled to work in the upcoming months? Is there a way that the load can be shared with the assistance of the registered nurse in the practice being more involved in the process? And of course, complying with the nursing standards and Medicare rules and everything else. But I think it's just be prepared, do the planning now.
And further highlighting the employees, whether it's the administrative staff or the medical staff. Sonia, what is the duty of the employer to monitor and assist with managing employees, staff, mental health? As there's certainly been an enormous stresses over the past few years, and continues to be so, between COVID, fire, floods, not really sure what else could be thrown at us right now. But what is the duty of care for practices?
Cheryl, the first thing that I'd like to do is to speak directly to all of the practice managers that are online. Now, I know many of you, I've spoken with many of you personally over, the recent years. And what I want to say to you as practice managers is that it's important to put on your own oxygen mask first. What I have seen more than ever over the past 2 years is that practice managers have borne the burden of stress from doctors, stress from staff, work stress, personal stress, and they have soldiered on. And I want you all to know that I recognise how much stress and pressure you've been under, and what a stellar job you've been doing to keep everything together. But you need to take a minute to recognise it has been stressful for yourselves as well, and to deal with that. Now, coming back to Cheryl's question, stress and mental health issues are getting increasing recognition as a workplace health and safety issue. Workplace health and safety has moved on from physical injury very much to psychosocial hazards and mental health. And practices have an obligation to conduct a risk assessment and to put time and energy into managing mental health issues. So what I say, and Cheryl and Mariana have heard me say this many times, over the last 2 years, you probably can't count how many hours you've spent sitting in rooms talking about the risks of COVID and what you're going to do about COVID. What you need to do is you need to have those same discussions and that same risk management approach to psychosocial issues such as mental health, such as sexual harassment, such as bullying, because that's where the investigators and the regulators have moved to. They want to see your risk assessments. They no longer want to see just your sexual harassment policy off the shelf, or your bullying policy, or your dealing with difficult patients policy. They want to see your risk assessment and what steps you've taken to deal with these issues in the workplace.
Oh, that's a really good point, Sonia. I want to concur. Getting back to your point about the stress that practice managers have been under, still continuing to communicate with practice managers I've worked with. Absolutely, they're all overworked, under-resourced, and at risk of burnout. So I absolutely concur with your comments and do encourage everybody to make sure you look after yourself first. Sonia, to that point again, getting back to the being short-staffed, many nurses have left general practice during COVID and employed elsewhere, such as the COVID ward or vaccination clinics. Many practices now employ enrolled nurses to fill this role. When things settle down, which we hope they should in due course, registered nurses may wish to return to private medical practices, and can the employer then tell the enrolled nurses that her hours have been reduced? Do they have the opportunity to make changes, and is there a consultation process required?
Well, I think the first thing is when that time comes and registered nurses are, highly employable by practices, first of all, we all need to do a little happy dance, because that hasn't been the situation in recent years. It's been next to impossible to get an experienced registered nurse in practice. And after we've finished our little happy dance, what we really need to do is we need to do a business plan. And doctors are notoriously terrible at this. They want to leave all of the business planning and the business management to their practice managers, and they just want to be a doctor and see patients and treat patients and not a business owner. But what really needs to happen is a business planning process where the practice management team, so that's the practice manager, the doctor owners and others, sit down and actually think about the business of the practice. Is this practice growing, shrinking? Do we want it to stay the same? Are we going to move premises? What are we going to do? And then after you've sort of decided those high level business ideas for moving forward, that's when you look at your staffing needs. And you might decide that you're growing your business, having one enrolled nurse with remote supervision from an RN somewhere else is no longer the way forward, that it's too risky. As part of your risk assessment process, you might decide having a junior EN is just too risky, and that you have a genuine business need for a registered nurse. In that case, there are processes that you need to follow in order to do a restructure of your business and potentially make the enrolled nurse's employment redundant. We can help you with that. If you just contact the MLAS line, if you're really lucky, you'll get on to me, but we've got lots of other very experienced people who can help you as well to talk you through those restructure processes.
Thanks, Sonia. Mariana, since the reduced ability to employ nurses, and in some practices enrolled nurses in particular, can medical assistants be employed to do the same job as an enrolled or registered nurse?
This is an ongoing problem and an ongoing question, because we know with the shortage of staff in the nursing situation, some practices have wanted to utilise their reception staff, for example, as medical assistants. And it's not as simple as that. You've got to really be thinking about the scope of practice. So what you are using the term a medical assistant or a clinical assistant, is that person trained to do so? And there is formal education and training available through University of New England, through the TAFE. And I would encourage a lot of you to actually consider putting some of your staff through that, because it's a great resource for your practice, and it's part of your planning and strategy. Really, that could be very beneficial. But you've got to just be so mindful that they are competent to do so, and therefore, once they've been trained and they've completed their education, make sure a formal competency assessment is conducted and documented, that they are okay to do the tasks that you are expecting of them as a medical assistant. Those tasks have to align with what they are competent and trained to do. They cannot start stepping into the nursing area of for example, giving vaccines or whatever. They're just going to be very, very mindful of how you're going to be using this medical assistant and who's going to supervise them. And quite often in the practice, it will be the nurses who will probably be part of that supervision and training. But it needs to be very clear what structure is going to be in place, what sort of mentoring, what sort of training, who is the one that's going to be directing them and supervising them, etc. And even on that point, I think it's really important to remind the practice managers, or if there's any registered nurses or even the doctors online, that I've always thought it's a silly process. It's a silly rule, if you like, legislation. That registered nurses cannot be supervised by doctors. They actually have to be supervised by another registered nurse. Enrolled nurses have to be supervised by a registered nurse, not a doctor. A doctor can direct a nurse to, do the treatment for the patient, but they are not theoretically supervising. So I think it's always important to make sure you are reminded of that. And theoretically, each nurse should have their own sort of supervisor. It doesn't have to be on site, it can be remote by phone or whatever. We've also seen a few issues I've seen from a risk advisory viewpoint where some of our doctors have got into a lot of trouble because they've used international medical graduates. So a doctor that's come from another country who may be very experienced and registered in their own country, they've come to Australia, they haven't sat the AMC exam, so they're not registered with AHPRA. And a couple of the doctors that I've come across have used these sorts of doctors who are not registered with AHPRA as clinical assistants or medical assistants. And they get into a lot of hot water because they are still sort of referred to as a doctor, or the patients know that they were a doctor in their own country and they don't know the difference. So they think they are a doctor. It's that inference of managing patients' expectations of what is this person registered? Is that person registered as a doctor in Australia? No. So they have to be very clear with what they can and can't do as well. And they cannot work as a doctor in Australia unless they're registered.
Gosh, very complex, Mariana. And I'm aware that there's lots of doctors and practices who've contacted Avant asking advice around similar issues. So getting back to Avant, and from a risk advisory perspective, if practices have any questions about that, absolutely contact Avant and get some advice specific to your needs. As you can see from what Mariana is saying, there's so much complexity in it all. It's a minefield. Talking about complexity, Mariana, telehealth and Medicare rules can be confusing. What are the key points for the ability to conduct consultations via telehealth and Medicare?
I think one of the most important things to remember is this 12-month rule, and that is that patients have to have been seen in the practice within the past 12 months to be able to conduct telehealth. Now, we know that there are some doctors who don't want to return to the practice, as we've already talked about, so they think they can continue to do telehealth. I think there's 2 points here. One is meeting the patient's needs. Some patients still don't want to return and they want telehealth, but what I'm seeing is that more patients, and probably all of you are seeing it as well, more patients are actually getting a little bit tired of telehealth and they actually want face-to-face consultations. But just make sure if you are doing telehealth, the 12-month rule does apply, that the patient was seen within the practice of the past 12 months. Make sure you're familiar with the telehealth guidelines. And also if somebody is conducting telehealth and they see the need for an examination, then they need to be very, very clear that that patient is able to go into the practice and be physically examined, either by that doctor because they go into the practice and schedule it, or by another doctor in the practice. Now, I know the 12-month rule may not apply to a non-GP specialist, for example, but they still need to ensure that they are compliant to the telehealth standards and Medicare rules. Make sure there's detailed documentation to support your telehealth consults, and that includes offering a video conferencing, and if the patient refuses that and says, no, I want it by phone, that should be notated. Make sure that you inform the patient about the billing process, inform financial consent. Remember, you can't bill the patient with the consultation until after the consultation, and from time to time we're hearing of practices that are billing the patients before the telehealth because it's too hard to do it afterwards. That breaches the Medicare rules. You cannot invoice a patient or get a patient to pay prior to the consultation. It's really interesting to note, and I don't know, because you're in Victoria, and luckily for you guys at the moment you haven't been exposed to the floods, and let's hope you haven't been, but interesting to note that there was an exemption in the current flood time, or to the 12-month rule, that people could actually conduct telehealth if they were in that flooded area zones and weren't able to physically go into the practice. But be careful not to abuse that as well. And I think it's really important to resume patient face-to-face appointments because you're potentially, sorry, not just the doctors, but the nurses in the practice, and even the value of the practice manager picking up on those physical cues that the patient may not be in a good space. The facial cues are sometimes not as good on telehealth because the ability to see somebody clearly on Skype or whatever may not be as good. So getting patients back into the practice, I think, also has an element of being able to pick up on the cues that the patients might be struggling. There may be actual mental health issues. And, I think we need to be really mindful. As you know, it's been talked about so much. Sonia talked about it from a point of view of practice managers and the oxygen marks, which I loved that expression. I think that's so good because I think too often practice managers tend to keep driving themselves to the nth degree where they just don't see that they're getting burnt out themselves. But I think it's just so important that the patients are really identifying that there are a lot of issues out there in the community. And as you know, some of them can't get into psychologists, psychiatrists, the waiting list is huge. So I think that importance of bringing them back into the practice is really important. And I think there are some patients who are getting a little bit cranky with the doctors that they normally see who just want to keep doing telehealth. They want to actually see people in person.
Very valid points, Mariana. I think we all recognise the importance of getting patients back to the practice to have a face-to-face consultation. But how do we get the patients that aren't so keen to return back to the practice, who think that it's not necessarily safe to return? What are some of the strategies that we could put in place in practices to assure patients?
I think there are a few elements to this. First of all, I think one issue that is quite paramount, and we're all very aware of it, is that patients have been reluctant to return. And as you know, through COVID, you'd hear so many discussions, and you'd have seen them in your own practice, where the patient may have had cancer, they're delayed treatments, or there's delayed diagnosis for other issues. And so that's a real issue in your practice. There are patients perhaps who are not getting treatment for whatever the condition is, or even a suspected condition where that has to be followed up. So to try and educate patients about the importance of the continuity of care and that there could be something important that needs to be monitored for them, make sure that recalls that you have in place to recall patients back into practice includes providing patients with detailed information of why it's important for them to come back, so that they actually understand the risks, the clinical risks to them if they don't come back. I'll often use an example of if you're sending out a recall, and particularly if it's a non-compliant patient, and you use the example of a registered letter, that doesn't even have to go as far as a registered letter. If you're really concerned about a particular patient that you want to come back in, don't just send them a recall, send them written information of what the risks are to them if they are not looked after clinically, because that will help their understanding, I think, and manage their expectations of why it is so important to come back in. And I think the way to let patients know it's safe to return because of their fear is to reassure them with information that could be on your website, on your message on hold, and scripting the receptions to reassure patients. And that can include giving information that regular assessments, risk assessments are conducted in the practice to protect the patients from transmission, and that they will be expected to wear masks to reduce the chance of COVID infection transfer, and other arrangements that can be made if the patient feels particularly vulnerable, such as providing the patient the last appointment of the day. Getting that sort of messaging out there that we are looking after you, and there are potentially other alternatives where we can do that if you're really concerned. Let's have that conversation.
Thanks, Mariana. Sonia, do you have anything to offer to encourage patients to return to the practice, particularly due to COVID?
I'm going to take my lawyer hat off for a minute and put my mum hat on. Kids in the practice over the last 2 years, there's no toys, there's no books, everyone's got a face mask and looks a bit scary. There's no cuddling or touching or any of that usual stuff. the ones who are old enough, well, all kids, their experience of medical in the last 2 years is someone shoving something up their nose that hurts, or someone putting a needle in their arm that hurts. So I would just, as a mum, I think it's really important for us to start thinking about how we can encourage kids and mums and stuff back into the practice, so that they will have a positive experience of a visit to the doctor.
Thank you. Yes. Now, Sonia, moving on to a different topic, which is becoming a significantly emerging issue. We're hearing so much chatter about PROTA and how this is affecting the doctor who is contracting to the practice compared to being an employee. Have you got any thoughts in relation to this?
Well, first of all, I'm just so glad that another change is coming, because we've all been a bit bored and haven't had much to do the last 2 years. So it's really good that they're keeping us on our toes with something further. Now, I'm going to talk about this issue globally rather than specifically on PROTA. So the issues in the last year or two, there have been a number of court decisions, firstly about whether doctors are entitled to superannuation, and secondly, whether doctors, the Medicare and other billings that come into doctors are subject to payroll tax. And then thirdly, there was 2 High Court decisions about 4 weeks ago, which changed the law to some extent on this distinction between who's an employee and who's a contractor, and what does that mean for people. Now, the PROTA changes, I'll let Mariana and Cheryl talk about the risk management and what that means practically. But what it means from a legal perspective is that the government can acquire a lot more information about the nature of the workers that you engage and how the money is flowing through the practice. And that can potentially lead to an increased risk of a finding that a doctor's an employee with employment entitlements, or that payroll tax is payable on amounts of billings and other things. So Mariana or Cheryl, one of you might just do a quick summary for those who might not be familiar with the PROTA changes, just of what is coming.
I think there's a couple of important elements to this, and I'm just going to say a couple of things, because I think Cheryl, who has been a practice manager quite recently of a large practice, would have more practical things to offer. But there are a couple of issues that the risk advisory team have actually been talking about, and I still do it. We tend to call our doctors contractors. We need to be very careful not to use that word and call them contracting doctors, because there is a potential, as the tax office says, how are your doctors working in the practice? Are they contractors? Then, Sonia, does that automatically infer the employee type arrangement, rather than if they are contracting doctors? There's a very definitive line there. Do you want to just comment about that?
Yeah, sure. So the issue with the payroll tax and the superannuation in particular is that a doctor doesn't have to be an employee at common law for there to be a payroll tax or superannuation liability. They have to be a worker, and the term worker has a statutory meaning that can include certain contractors. So with the payroll tax issue, the two cruxes really are firstly the money flow. So what the payroll tax decisions have said is that where the billings, the Medicare billings, DBA, private billings, whatever, the usual practice in a lot of practices now is all of the money goes into a single practice account. The practice then takes out its service fee and it distributes the balance to the doctors. So the payroll tax decisions have said if that's the way the money flows, there's a significant risk that that is part of the payroll for the business, and that payroll tax is payable. And the preference is for the money so the billings to go to the doctor's bank account 100%, and then for the doctor, for the practice to issue an invoice to the doctor for the service fee and for the doctor to pay over the service fee. So that's the first.
That's quite an issue at times, isn't it? And this is where I think it'd be very interesting to hear what Cheryl's view is, because there's a cash flow problem there, because quite often my experience has been that, you know, if all the money is from the patient billings is banked into the individual doctor's account, and then the service fee is got back by the owners by producing an invoice for that service fee, the doctors can take quite some time to pay that money. So there can be a real cash flow. The other issue, and I'd love for Cheryl to comment practically on this, is if you've got 10 doctors in the practice, does that mean they each have to have an EFTPOS machine? And I understand that's not the case. But where it's an issue potentially, and it'd be invaluable to hear Cheryl and other people's comments, if it's not the one bank, say if all the doctors aren't with Commonwealth Bank, you can use one EFTPOS machine generally, but if they're not all with the same bank, does that make it problematic? And Cheryl, you've had recent experience with this. How does that sort of practically work?
Yeah, thank you, Mariana. So I came from working with a practice of 27 specialist anaesthetists. We made a decision that each of the doctors was going to have their billings directed directly to them. And it came down to a business plan and ensuring that we actually retained enough funds that we could cover those, because you're right, Mariana, some doctors aren't quite so quick at paying the service fee invoice. The other challenge when I first started, we did have a number of EFTPOS machines because each of the banks require their own EFTPOS machine in order to take credit card payments. So what we did was a system response, and it would be up to your individual patient management system and billing system to identify what is possible. So I'd be talking to them as well as to the banks. So with 27 anaesthetists, we certainly didn't have every one of them with the same bank. So the challenge that we had was, how do we manage a facility without having a front desk with 27 different, or potentially half a dozen different EFTPOS machines? We used a payment gateway. So this was something that was embedded into our software. And that's where I'd encourage you to talk to your software vendors about what's possible from a system approach. But we input the patient credit card details into the system, and it went directly through the merchant facility and then back to the doctor's actual account. So we as a practice never actually held or received any of the funds. And it will depend on what the system is. I haven't explored whether there's also a possibility. I understand with some of the EFTPOS machines, you can have a number of different doctors and identify which doctor is actually being paid on the EFTPOS machine, but that may be required that they're all at the same bank. So you could potentially work around that by having 3 or 4 different EFTPOS machines if your doctors are across 3 or 4 different practices, or speak to medical director or whoever else you're working with to identify whether there's a system opportunity to be able to utilize a payment gateway or other facility.
Yeah, that's really practical advice. Yeah.
So getting back to payments and this cash flow, Sonia, if one of our doctors that's contracting to the practice was paid a PIP payment, does that then alter the PROTA effect?
No, so a single PIP payment is not going to be the deciding factor. In addition to what I call the money flow, how the money flows, the other things that the courts have looked at in the payroll tax cases are the level of control that the practice exercises over the doctors. So what we've been increasingly recommending at Avant is that historically doctors were engaged by the practice as contractors to provide services to patients of the practice. What we're increasingly seeing and recommending is that the contracts are set up in such a way so that the doctor is running their own medical business and they are engaging the practice to provide practice management services to the doctor. So that's one factor that they look at. Another factor that the courts have looked at in terms of this control and direction are things like the practice's ability to direct hours of work, restraint of trade clauses, indemnity clauses. The more of that sort of control and direction that the practice holds over the doctor, the more likely it is that the doctor will either be found to be an employee or a worker for superannuation and payroll tax purposes. So there's multi-factors to look at, I suppose, Cheryl, is the short answer, and a single PIP payment's not going to matter.
That's probably good news for lots. Mariana, moving on to, and we talked about flu vaccinations earlier. If a practice is asked to manage flu vaccinations for a corporate and its employees, what are the issues from a risk advisory perspective here?
So Mariana, you're on mute.
A lot of people might be very happy about that. My husband probably would be. If a corporate approaches, say, Dr. Jones's practice, and they want Dr. Jones to organise flu vaccines for their employees in the workplace, say if it was such as a VANT, which is a large numbers of employees, and they approach Dr. Jones's practice and says, can you organise the flu vaccines for the employees, but can we do it in the event offices? That's absolutely fine, and quite often they'll set a registered nurse to do that. The issue there is, there's a few multifactorial issues here really, is you cannot charge Medicare for that sort of service. That would be quite often the corporates will come to an arrangement where it's a sort of like a bulk payment for everybody. You can't individually charge Medicare for those employees when you're going into the workplace. If the practice is going into the workplace, then you need to make sure that the same infection control standards are complied with, the same consent process, documenting. You've got to make sure that you're compliant with the STRIVE 5 standards with storage of vaccination. So there's a lot of issues with that. If you are running flu vaccines in your practice, that's a very different scenario. So obviously the doctor's on site, the doctor's engaged, often the doctor will come into the treatment room. The nurse is very involved in this process, the documentation is good, the consenting process is good. So it's a very different scenario, and therefore obviously that individual patient can be billed from Medicare's viewpoint. So I think you just got to be really careful how you're doing it, whether it is for a corporate, be very careful, no Medicare. If it is for your clinic, make sure the normal process that is expected to be in place in the past remain in place.
Thanks, Mariana. So Sonia, if in this setting and a nurse will be administering flu vaccinations to corporates and is a consultant to the practice, so the practice contracts the nurse, therefore they're considered a casual employee in this way, or what are the potential employment related issues here?
Yeah, good question. And, it went all the way to the High Court 4 weeks ago. So you're in good company asking that question, Cheryl. The most important thing now, as a result of the High Court decisions about the difference between employee and contractor, what they've said is that the written agreement between the parties is the key. And if the written agreement between the parties is set up so that someone's engaged as a contractor, then they're a contractor, regardless of how the parties actually interact and the conduct that later occurs. So if you're engaging nurses to go around to corporates or to other bodies to do flu vaccinations, the most critical thing is to have a written agreement in place that makes it very, very clear as to whether the nurse is a contractor or an employee. That's the first issue. And the second issue is on the back of last year's decision about casual employment. It's really important, if they're to be a casual employee, you need a very clear statement in that written agreement about the nature of casual employment.
Wow.
Yeah, so there's lots of C's going on in the High Court, contractors and casuals at the moment. The other thing to be very clear about is, for a nurse who's engaged, for a flu season to do flu vax, you might engage them as a fixed term employee as well. So that's another issue to throw into the mix. We have had some questions about dealing with difficult and distressed patients in the practice. Now, Mariana, you and I have talked at length about that before. What are your tips for practices dealing with difficult, mean, nasty, violent patients?
Well, the violent part, I mean, this could be a whole session on its own, of course, so this is only going to be a very brief overview. The violent part, as we're all very aware, you need to have strategies in place, both to look after the employees and other people that are in that practice, including patients. You need to have a safety plan in place. What I often hear in the practices when I talk to them about this, when we're doing risk advisory support, I'll ask them if they've got a safety plan, and they'll say yes. And I'll say, what does that look like in reality? So if a doctor is in a room consulting and he or she has a panic button and they do have a very angry patient who they are worried is going to become violent, if they press that button, what happens? And quite often when you ask that question, a lot of the practices, staff will say, well, I think it goes up on the computer. I think we see it at the front desk. Do we see it at the front desk? It's like no one's practicing. So I often think that it should be part of a drill, a little bit like your fire and evacuation, so that if this happens, what's the next step? Whose responsibility is it for what? And delegate. This is what each person's role is if this occurs, to make sure that that's really clear. Other issues around the safety, and there's RACGP have got a great resource about safety in the practice. But other issues, particularly I think very quickly to talk about, is to make sure that if your staff are working back, and particularly as winter's coming in now and it's going to be darker earlier, make sure that their car is brought up close to the practice where there is plenty of light and they can access that car quickly afterwards. Some practices will also provide a panic button where the staff will wear that around their neck after hours whilst they're locking up, etc., and that's connected to a security service. But I think as far as dealing with that patient in front of you, again, I think you need to have very clear strategies, do some role plays, ask yourself also, is it the patient who's being difficult, or is it just a difficult situation? Is it you? Are you contributing to that? Know your own limits, because all of us have been under stress, particularly all of you that have been dealing with running practices through COVID and floods and everything else, and fire last year. So encourage the patient's engagement in a positive way when you're working through the actual communication, whilst trying to manage this difficult situation. Try and remove them from the public view, because often, as you're very well aware, once you remove them from the main waiting area into a private room, as long as you're safe, keep the door open, whatever. If they haven't got the audience, they'll tend to back off a little bit or calm down a bit. Open boundaries, listen to what's important to that other person, acknowledge it. Make sure you are using active listening techniques, but avoid being manipulated. So make sure that you do set very clear boundaries for this patient. A lot of patients will have codes of behaviour, code of conduct, and as you would see if you haven't got it, you'll see them in the hospitals where it says our responsibility is to you, your responsibility to us. And I often encourage practices now not even to have that in their waiting room as a sign. So it's a reference point for any of the staff in the front, in the practice to say, these are our protocols here. If you don't comply, you won't be welcome back here. I also encourage now to include in that signage, in that code of behaviour, about social media. Something like, if you engage in social media negatively about anybody in this practice, you will not be welcome back here. Now, I know quite often you can't identify who that person is, but sometimes you can. But sending that message, and it's in the waiting room, may actually cause somebody to think twice about it. Look at the systems in your practice. Is it part of your systems that are contributing to this difficult situation? And it could be, particularly through COVID, we've had so many things to have to put into place, and patients see it as almost becoming more difficult. Sometimes the practice managers are a gatekeeper to their doctors. They're trying to protect them, and that doesn't allow for positive and easy communication for the patient to the doctor, and they often think that they're being blocked, and that would make them even angrier. So as I said, this could be a whole session. So just look at you know, what you do have in place. Do some scripts, do some role plays for the staff so they feel comfortable with how to deal with it. Look at any education that's possible to help reassure everybody that they can reasonably deal with these difficult patients, and make sure that you do look at safety protocols in your practice. What are the protocols to deal with somebody who's becoming escalated? Do your drills, make sure everybody's supported.
Mariana, in 1 minute or less, I want you to answer this next question. We are getting, particularly from our Victorian practices, we are getting more and more questions about terminating the doctor-patient relationship. Doctors, practice managers, reception staff are tired, and I think, and stressed, and their ability to cope with difficult patients is at a low ebb. So a lot of them wanting to terminate the doctor-patient relationship. What are your top 3 tips for doing so?
Okay, I think, first of all, we see too often that the doctors will often put that onto the practice manager or even the receptionist to phone the patient, which I think is really hard, and ideally shouldn't happen. It should be the doctor that has that conversation, but we know that doesn't occur. Like, try to engage the patient, try to have a conversation about, you know, these are the rules, this is almost a contract if you like. If you breach that contract, you're not welcome back here. Make sure that if you are going to terminate the doctor-patient relationship, don't hesitate to phone what we often refer to the MLA line, is the medical legal advisory line of event, to get assistance if you're not sure how to do it. We have templates to help you to do that. We can help with you draft a letter that you might want to see. We can review them. The most important point though is you just cannot dump a patient. You cannot just say you're not coming back, end of story. You need to be able to know and tell the patient there are 3 other practices in this area that you can go to. If you're in the rural setting, that's much more difficult and much more complicated. So if you are in a regional or rural setting where there's not that much choice about other practices, give a VANT a call to get some assistance.
Thanks, Mariana. Now we're running up against the cessation of this webinar. Sonia, just throw back to you for your last minute thoughts from today's presentation and things as a takeaway for attendees to consider when they go back to practically looking at their practices.
Yeah, I want to speak to the practice managers directly. Put your own oxygen mask on first, and a VANT is here to help you. Pick up the phone, ask to speak to me. We will help you through difficult employee and other issues.
That's great, Sonia. Mariana, same to you. Have you got any takeaways or practical suggestions for attendees?
Yeah, thanks, Cheryl. I think really very, very succinctly, just keep your focus on your planning, on your strategies. Keep revisiting, do your risk assessments. Don't let it be a static process. Keep engaging with your staff to see how they're going. Maybe even ask patients how they feel the practice is managing the current situation. Engaging other people is really beneficial, and also, as Sonia said, you know, Sonia's there for you, her team's there for you. Make sure you know that our risk advisory team very much are there for you. You can contact us. We'll help out with any advices that we can, any support that we can. But reiterating what Sonia said, it's been a really hard time for all of you. For doctors, for practice managers, for everybody, for all the staff. Look after yourself. Have some time out.
Thank you, Mariana and Sonia. Thank you so much for your expert advice and practical applications for some of these risky challenges that we are all facing. Again, anytime, there are resources on the Avant website, and feel free to contact Avant anytime that we can help.
Thanks for joining us, everyone.
Thank you. Bye.
Bye.